Welcome to the Network's Friday Forum, Mental Health Housing, Looking Back, Looking Forward. Thank you so much for joining. This is the second forum in a series of forums that we are hosting weekly on Fridays through June 25th. The series includes 6 more amazing panels during the month of June, including one later today on democratizing land use and zoning policy. Join us again at 1 p.m. for that conversation. I'd like to thank our sponsors and nonprofit partners who generously supported the series, and please check out our exhibitor gallery, the link to which is posted in the chat. While the series is called Friday Forums, next week forums will take place on Thursday, June 17th, as we will be observing Juneteenth on Friday. Please join us next Thursday for a workshop on restorative justice at 10 a.m. and a really exciting panel on wage equity in the nonprofit sector at 1 p.m. Links to register for those forums are posted in the chat as well. Also join us on Monday at noon for a workshop with Hollaback on bystander intervention training to stop anti-Asian American and xenophobic harassment, which is free and open to the public. The link to register is also in the chat, and please invite your colleagues to attend. After today's conversation, please also join us for a 15-minute post-forum chat with our panelists. The link to join that Zoom meeting was in your registration reminder email and will also be in the chat. Bottom line, keep an eye on the chat. Thank you again for joining us. Please introduce yourself in the chat and let us know you're here. We'll have some time at the end for audience Q&A, so please put your questions in the Q&A function. Now it's my pleasure to introduce the wonderful Diane Lougard-Michel, Executive Director of Lantern Community Services, to get this conversation started. Diane, take it away.
Okay, will do. I'd like to, first of all, hopefully everyone, all the panelists can come back on screen. But just to give some context, CUCS and Community Access were early adopters and evolvers and innovators in the supportive housing space. I can think back in my early career, and they were my go-tos. The Steve Coles and the Tony Hedigans were the ones who helped me think through what supportive housing is, what it's missing, and what it could do. So we're really honored to have their progeny and people who will continue to do that work today. Let me just start off by telling you and introducing 2 of the people who are here from CUCS. Stacy Matuza is a licensed clinical social worker. She's been with CUCS for 19 years, currently serves as a deputy chief program officer, overseeing 5 permanent supportive housing programs. Previously, she held positions as a social worker, clinical supervisor, assistant program director, and program director at various programs at CUCS. Gabby Gomez is also a licensed clinical social worker who's been at CUCS for 19 years and currently is the program director at Kingbridge Heights, a permanent supportive housing program for families. Previously, she held positions as a social worker and clinical supervisor in the CUCS Career Network, supported employment program, and she was an assistant program director at Leninger, another supportive housing program for families in the Bronx. One of the first ones that I funded when I was at CSH. I now want to move to, yes, it was my first one, the first family one. Now I would like to move to community access. And here we have Melissa Toonkel. She wears many hats each day. I think we can all relate to that. In the 3 years that she's been working at Community Access. She currently, though, serves as assistant program director at Bruckner Boulevard. She says that she will be now and forever a harm reduction specialist at heart. That is who she is, and that is all that she can be. She tries to be all that she can be. And last, I want to introduce Cal Hedigan, who was the CEO, executive director of Community Access. Cal has dedicated her career to creating environments where people living with mental health concerns can live with dignity. They can access connection and community and find allies who support them in their journeys. So with that, I want to kick it off to our amazing panelists for a discussion about where looking back and looking forward. Thank you all for joining us.
Great. Thank you so much, Diane, for that wonderful introduction. Welcome, everybody. Good morning. I'm going to share a screen here. Okay. Great. Okay, welcome. So as Diane had said, we are going to be talking about supportive housing and where we've come from, what we've done over the last several decades, and where we hope to go. So looking forward. So I think it helps when we are looking forward to and seeing where we want to go with things to take a step back and see where we started. So for CUCS, I'm going to give you a little bit of a history and background on the agency. So we started as the Columbia School of Social Work in 1979. And what happened was it started with a group of faculty and graduate social work students who wanted to take a look at poverty and homelessness in New York City. They wanted to take a look at this because there was clearly a need for intervention and to help the homeless population in the city. And through this project and exploring what was going on, they discovered that mental health issues were really woven into the fabric of homelessness, and that they really were hand in hand. And really what was needed was obviously affordable housing and for people to have homes, but that there needed to be something else in addition to really get at these mental health issues that were contributing to homelessness in the city. So we worked on that, and supportive housing has grown out of that recognition. We were established as a nonprofit in 1993 with a mission to help people rise from poverty, homelessness, and be healthy. And that mission really helps guide all of our programming, and in particular, our supportive housing program. This is, a mission that's very near and dear to us. We develop affordable housing and programming that links housing, healthcare, and social services for low-income individuals and families. So this is housing plus services, and it's the crux of supportive housing. And that was kind of the birth of CUCS, came from this. We started in the late 1980s with a series of programs in Harlem that are now called the Uptown programs. There's 5 buildings where there are affordable units for folks with mental health issues that have on-site services and services available to them. In 1991, we had our first large program open, and that's the program pictured here. It's the Times Square. It is the largest supportive housing program in the nation. It's 652 units of supportive housing in Times Square area of Manhattan. Since that time, we have grown to 19 supportive housing programs throughout Manhattan, Brooklyn, and Bronx. We continue to grow. We've got 3 additional programs in development and scheduled to open in the next 2 years. So we're pursuing more housing programs. It's very needed. And we're now one of the largest supportive housing program providers in the nation. At the crux of supportive housing are the on-site services. And so that's what really makes supportive housing special. So there's the affordability and the access, but the services on site are really what makes it work. And some of the highlights of supportive housing at our programs are integrated communities. So that is both internally and externally. So we really believe that integrating the community within the programs is really important. So you have individuals with varying needs living amongst each other. There's no division based on how somebody came into the program. It really is an integrated, diverse community. We think that benefits every person that lives within that building, but it also goes externally to the outside. So we want our programs to seamlessly work with the neighborhoods as well. So, if you're walking down the street in downtown Brooklyn, you're not saying like, oh, I know that's a program. It just looks like another beautiful apartment building, and it just works within the community. And again, we think that not just benefits our residents, but it really does enhance the communities around us, and is really a benefit for everybody. We operate all of our programs with a housing first model. So there are no requirements for treatment or sobriety. It really is tackling that need of homelessness first. Our belief is that everything else can come afterwards, that we really want to get at that, piece to get folks housed safely and stably. And that's super important. And that is why we have a housing first model. The services piece, like I said, it's the special sauce that makes our programs run so well. It's teams of case managers and social workers and supervisors that are on site working with folks to get their needs met and help them work on whatever goals that they would like to work on. This is a short list. It is by no means exhaustive, but it's some of the highlights that it's case management. So helping folks with connecting to resources, whether that's in the community or whatnot, being able to help with supportive counseling for folks who need it, crisis management and crisis intervention if that comes up, benefits assistance and financial counseling. That is something that we work with all of our residents on, and in the past year became even more critical when we needed to help people access unemployment benefits, or maybe somebody who had never filed taxes before is trying to figure out how to get their stimulus check. So those on-site services that had the knowledge and the resources to connect our residents to those services became even more important. Through now, with emergency rental assistance being available, really helping people navigate these complicated systems to get their needs met. It's really a benefit of having these on-site services on site. And all of our on-site services, they really are offered on a spectrum. So it really is based on the client need. So if somebody just needs help finding an office to go apply for unemployment, we can provide them with that information up through including more intensive help like representative payee, where we are budgeting a person's money with them and helping them learn how to meet their financial needs. And the same thing goes for helping folks with their health and mental health goals. So it can be something like just offering referrals through, a more intensive process, like assisting them with their medication. And again, this is all done through a clinical lens and in a person-centered way and based on their strengths. So it's not the staff doing things for our residents or telling them how to do things. It's really working as a team. So in the instance of helping somebody meet health goals, if they need help managing their medication, it's making sure that we're working together. Are these things that work for you? Have you talked to your doctor about it? Do you want to role play questions for your doctor? What can we do to help you get the skills to possibly not need this service and to become more independent? And if you need this long-term, great. But if we can get you to a place where you don't need to have this kind of oversight or this help, that's great too. We want to help people move, where they want to go to goal-wise.
I just want to add with that, because that's a really good point, is that even advocating within our own, with our own sites, advocating with our own psychiatrists, with our own primary care doctors is something that we do. We do not align ourselves a lot with our psychiatrists and medical team. We basically push for the agenda of the client.
Yes, thank you so much, Gabby. I think that's a great point, that everything is done within the kind of through the lens of being person-centered and in the best interest of the tenant, and taking that tenant choice, what they want into account. So when we are working with our psychiatrists or our doctors, any of our both internal and external resources that we have for our clients, we're really going through that lens. And Gabby is going to talk a little bit later more in depth about some of our medical programs and psychiatry programs. And that's a big piece of it, is making sure it's a teamwork approach and it is always centered on the person. So yeah, that is an important point. Thank you for that. This is another just a picture of one of our programs. This is the Stammerhorn in downtown Brooklyn. As you can see, just beautiful apartment building in Brooklyn. You wouldn't know walking by that. What kind of housing that is. And that is by design. So what I've given an overview of and talked about are the services that we offer in all of our programs. And these are really developed and honed in our work in our earlier programs, which are all with singles and individuals coming in to our supportive housing programs. But on this journey, we have expanded who we are serving. And beginning in around 2011, 2012, we started to develop and to open supportive housing that not just met the needs of individuals, but also families who have been homeless and have been impacted by mental illness, because we recognize that this is also a population that is very large. Our family shelters in the city are full, and that there are needs that we think we could meet for these families in supportive housing that we had been meeting with individuals. So this is kind of our newer developments. We're moving through time now to some more recent programs. And this has been a really interesting process for us to develop these programs and open these programs. We're up to 5 programs right now that serve families. Because we've looked internally at what we've done at our programs for individuals, but decided what works in individuals that could work for families, what needs to be different. But we've also taken our learning outside of CUCS, which has been hugely valuable. So we've consulted with agencies in Minneapolis and San Francisco that provide housing for families and learned from them, and as well as had a lot of conversations with many providers in New York City about what you all do when you're working with families and what's really beneficial and what we really need to be thinking about as we open these programs and expand into future programs for families. And Gabby has been a very key part of those discussions and part of this work over the last several years. So I'm going to turn it over to her, and she's going to talk a little bit more about where we've gone and what we're developing in terms of our family housing, as well as other special services and evidence-based practices that we're incorporating into all of our programs that we also think enhance all the services that are already available to folks in our housing. So Gabby.
Thank you, Stacy. And I love that picture. It's a very good reminder of the families that we pretty much serve and the struggles that they have gone through to get to where they're at this point. Family housing has been incorporated in our recent programs at the beginning of 2009. It was a shift to providing housing that serves families to meet the very high need. Families come from the shelter system, most in the system for the past 2.5 years. So a lot of them coming in are pretty much thrown off with the idea of permanency and of now paying their own rent and paying their own utilities and having all of these responsibilities. What we also notice is that they struggle with engaging with each other. They're now learning how to communicate with each other, connect with the relationship with a mother and son relationship or a husband and wife relationship. And that's because they've been in the shelter system and in survival mode for so many years that when they start settling down, it's like this rude awakening of like, you know, I may not like you. And how can I work to build this relationship and continue on, right? We don't have the same ideas, and how can we move forward with that and provide what we need to provide for our kids. So the approach that we take is family focused and incorporating the clinical piece of work based off of the family systems theory. And the family centered approach is inherently collaborative. It involves collaboration with families and with team members who support specific aspects of the family program, such as the caseworkers, case managers, social workers, family services coordinators, the education activity specialists. Now, the family services coordinator and the education activity specialist are new positions at family sites. They're basically the liaison between families and the social school system, as well as the communities. So it's a huge role to play and such an advantage to our families. So family-centered practice believes that the most effective way to ensure safety, permanency, and well-being is to provide services that engage, involve, and strengthen and support families. The family-centered model, which views families as having a capacity to make informed decisions and act on them, differs from models in which professionals make decisions alone or with only the assistance of the family. And we've seen that just based on our conversations with families and what we've seen in other sites as well and other agencies. So we also provide necessary concrete services such as connections to tutor, after school services, legal representation for child welfare cases, And other specialized services are Career Network and Diane, which we mentioned. And Career Network started at UCS, I want to say late 80s, but I'm going to say 90s for now. It was a vocational program, and basically it offered 4 tracks, and the client needed to fit in these tracks. So it wasn't customized approach. So as in 2007, Career Network was then incorporated. So the evidence-based supported employment model was incorporated in 2007 into all of our housing sites, and person-centered and strength-based. It followed the supported employment principles and practices, basically, which are a zero exclusion policy. No one was excluded for reasons such as symptoms or substance use or poor work history, grooming difficulties. Definitely client preferences are important, so they were customized positions that were worked on with the help of the employment specialist and the client. Definitely competitive employment was the goal. It wasn't stipends or anything that was less than. It needed to be competitive employment so they could sustain themselves and feel like if they were financially secure. And of course, the supported employment is integrated with other services. So that means employment specialists may share office-based treatment, team specialists to meet share experience, expertise, and coordinate planning services with participants. So then Diane is an affiliate of CUCS offering psychiatric and primary care to the homeless and formerly homeless individuals living in New York City. On-site Diane services eliminate barriers and produce better health outcomes, as we have seen in our sites. Psychiatry is incorporated in all our supportive housing sites as part of a team approach. It takes on a more holistic approach. And what I mean by that, it's not in the traditional sense, it's more integrated in a person-centered model. So if psychiatrists and clients just want to have a talk therapy session on a consistent basis, and that is it. Medication is not a requirement or a barrier to the services. And primary care also incorporated into most of our housing sites, pretty much meeting with support staff on a weekly basis, which is the same as psychiatrists, as psychiatrists. So now I will turn it over to Stacy so she can talk a little bit more about what's next in housing, and I'll come back to talk a little bit more about some family side stuff.
Great. Thanks so much, Gabby. So we've looked back, we've kind of gone through how we've developed over the last several decades. So now we're looking forward. And when Gabby and I and some other folks at CUCS were talking about this presentation, we're like, well, let's create a wish list. Like, what are the things that we would love to see happening in our housing and in supportive housing in the city and nationwide? What are the things, we've done all these things, what's next? What do we think could further enhance our programs, further benefit our tenants in supportive housing? And I think kind of piggybacking right off of what Gabby was talking about is enhancing the health services at our sites and that are offered to folks, we think would be a huge benefit. We've already seen that we can really help improve folks' health outcomes when we reduce the barriers to care for primary care. So why not expand that? So women's healthcare is an issue, I think, that's really important to us, and that we think enhancing our services to include more robust women's healthcare services would be really beneficial to our tenants. We know that many women, their healthcare provider is that person who specializes in women's healthcare. So we think that would be a great addition to supportive housing, as well as dentistry. That's it's a need for everyone. And it's, typically pretty hard to access for folks who don't have really robust insurance or income. So we think amplifying and kind of getting better connection to dentistry services would really benefit residents. And, as Gabby and I have been talking about expanding our programming to families, to be able to expand services to into pediatrics would also have a be a great benefit. Right now, our services, both primary care and psychiatry, are offered to folks 18 and over. So to be able to incorporate some more pediatric care, whether that's, helping do school physicals through like full range of pediatric services, adding that will always have like a positive impact. And then going from pediatrics to the other end of the spectrum, talking about housing for older adults and seniors, or just adding more robust services for our folks who are aging in place. We talk about the Times Square or the Prince George, our older programs that opened in the early to mid 90s. We have residents in there that moved in during the time that it were opening, and now it's 30 years later and their needs are changing. And what can we do to make sure that they can maintain their independence for as long as possible? And that could range anywhere from bringing in additional services like occupational therapy could make a really big impact, to concrete adaptations in their apartments. And these are some things we've already started doing, and I think we can continue to look at more, like grab bars and maybe some type of aids for hearing loss or vision loss or memory loss, really looking at ways that when folks are in our housing, that we can keep them in there as independent for as long as possible, I think is a very big benefit. So those are some of the things that we had come up with. Now I'll kick it back to Gabby to talk about a couple more items we talked about as we tie up our piece.
So with family housing, so many things can be done, right? But we continue to grow and adapt our model, and this is a result of learning from other programs, a lot of providers of family housing in New York City and nationwide. For future supportive housing, we would like to continue to see more development in housing, and that includes integrating more intensive partnership like after school programs and tutoring and neuropsych testing, family legal services. And with family legal service, what we noticed was that when we have ACS cases and moms are being dragged to these court situations, they're not represented fully. They're pretty much assigned to lawyers who may not be 100% there with the client. And so there was a lot of advocacy in our part to jump in, to get more involved, to push the agenda for the client. So to have possibilities of getting, private lawyers or representatives on the side for them would be such a great opportunity. And this would address any ACS cases as well as DV situations and also divorce cases. So then another wish list, item on the wish list, is a building design. And so we had many aha moments with this. At Kingsbridge, we have an amazing outdoor space, backyard area in which you have an opportunity for families to go into the backyard, have eat or have meals, snacks, sit down, enjoy the weather, have a playground area, the children are playing. It could be such a wonderful experience. And of course, we have the opportunities to also facilitate with activities out there. So it's such a great space to utilize in so many ways. And so that's something that we do recommend for all family sites, especially. Location of staff offices. We are located here at Kingsbridge. We're located in the basement. We like to call it the cellar. So at least it has a little fancier ring to it. But it's us being down here and not in a high traffic area, which would be ideal for a lot of housing sites. The staff being more visible would be such a great asset opportunity for families to quickly just come in and troubleshoot situations. So that's something that we thought of. And of course, amenities in units. I mean, the dishwashers were just, it was, parents' minds were just blown when they saw these dishwashers. First of all, they were not aware how to use them, so we were teaching them how to use them. But then they would just give us feedback regarding how it was so amazing to just have these dishes put away, and they would have time for their kids, and they would have time for other things that they may want to be doing. So it was such an advantage for them, and it was such an emotional response to it, which was really interesting. And also durable materials that can withstand a child's curiosity and creativity. I mean, these walls become amazing canvases for our kids, especially that one on screen. Yes. It was a lot, it's paintings amongst drawings of so many things, and the paint that was used in buildings are normally flat paint, which recommend gloss for sure. And also with building wide broadband and internet access to all, this has basically been such a huge issue in the past 1.5 years with our families who have children doing virtual learning, and trying to get them into the system and trying to get their Wi-Fi working in their apartments was huge. People, we had to pretty much intervene and have them use our office space or trying to figure out a place in the building to get their services going. So that's something that should be looked into across the board. So this is our wish list, and this is what we would like to see in the future for supportive housing in the next 5, 10, 15 years. And I'm sure that all of you have many more ideas around this area. So I am now going to turn it over to Cal from Community Access. Hey, Cal.
Thank you, Gabby and Stacy. And Emily, I'm going to give you like free reign with the PowerPoint to just move ahead with the slides as you see fit. CUCS and Community Access have a long shared history as supportive housing providers in New York City. And I think in some sense, we've grown up together and we share many similarities, and there are also a lot of differences in how we approach the work. In listening to Stacy and Gabby's presentation, I was reminded of my first job in New York City in 1989 when I was a case manager in the Brooklyn Women's Shelter. And my training, as all the training for entry-level workers in these new New York funded programs came through CUCS. So I wanted to thank you also for your contribution broadly to supportive housing in New York City. I want to talk a little bit about Community Access's origins. We began in 1974, founded by friends and family members of patients in Manhattan State Psychiatric Center who got together to try to create an organization that could really help build housing and community supports to help people transition successfully from inpatient settings to their own homes in the community. Today, I guess like 46, 47 years later, we operate over 1,400 units of housing in 23 sites in 3 boroughs, the same boroughs, interestingly enough, as CUCS. And housing is our origin and the core of what we do, but we also have a number of other non-housing services. And I just want to highlight one of them, the Howie the Heart Peer Advocacy Center, which since 1995 has been training users of mental health services to become providers of mental health services in New York City and beyond. And we've graduated over 1,500 people in that period. And I think those people working in settings throughout New York City are also, each one of them, helping to transform our mental health system. In terms of our housing, some key features of our housing, similar to CUCS, a housing first model where our job as a provider is really to have our doors wide open to make sure we are not creating barriers to entry. Harm reduction is a core of how we work, both in the traditional sense of people who are struggling with drug and alcohol use, but also in any kind of behaviors that may be creating risks and harm for people. We have a very simple view on harm reduction. It is, we meet people where they are, not where we would like them to be, not where we hope, and that is the guide to our services. In addition, our supports are always flexible, driven by that individual need. And we try as much as possible to really look at ways that we can broaden what community integration looks like in supportive housing settings. And that means for us that our preferred model is a building where we are housing people living with mental health concerns along with families. We opened our first our first building like this on East 4th Street in the early 1990s. And through that experience, really saw how it can be a game changer in making sure that these buildings look and feel like any other apartment building. Another important thing I think that we've added over time to, well, I guess it was a long time ago now, let's say it was close to 15 years ago, we opened up our buildings to allow tenants in our buildings to have pets for a whole range of reasons. But one of them is it also creates opportunities for community building within the buildings and within the outside world, where I'm sure any of us walking around in New York City can see people gathered around their dogs, and it can really just help people develop connections and create supports that are not based on their mental health diagnosis or where they live, but come along with pet ownership. So I think at our foundation, community access is rights-based and value-driven. Our vision is to develop environments where people can heal from trauma, including the trauma that they have suffered in the traditional service system. We work very hard to avoid recreating the oppressions of the larger mental health system. And my shorthand for that is that in our work, we are looking for less coercion and control and more connection. We are, the last line of our mission statement is that we are built upon the simple truth that people are experts in their own lives. And what that means is that our role is to be an ally, to be someone who listens, to help facilitate informed decision-making, to help people make connections to resources in the community. But our primary role is to listen to the people we serve. Over time, we've developed 5 values that ground our approach: human rights, self-determination, harm reduction, healing and recovery, and peer expertise. When I came to Community Access in 1999, it was because of their explicit commitment to self-determination. And it was one of the only organizations at the time that was taking a rights-based approach to mental health work. In our commitment to that, we also created an organizational goal of having at least 51% of our staff identify as users of mental health services. And in order to facilitate that, in the mid-1990s, we eliminated educational requirements for most of our roles. Obviously, if you're a nurse, you're going to be a nurse. But in all of our direct service roles and program manager roles, within the context of our housing, we do not have any educational requirements beyond a high school diploma, because we really want to open up our workforce, to open up opportunities for people, and to make it so that we can have a workforce that reflects the people that we serve, so that we are not in a sort of expert recipient dynamic, and there is no us versus them in our approach to the work. And now I'm going to turn it over to Melissa, who is one of our amazing employees. Thanks, Melissa.
Melissa, can you unmute?
Yes, that would help. Hi, everybody. So I actually have a unique hiring story, and I think that's one of the reasons why Cal asked me to speak today. So I always, when I tell it, start with saying that, like, at the time when I applied for community access, I think I was in the middle of trying to get my associate's degree. I think I was working at a supermarket. And, you know, I've been street homeless. I went through the shelter system. I'm a former substance user. I have a criminal background where I've been arrested 11 times. So, you know, I have a lot of odds stacked up against me in the professional world. So I put in a bunch of applications. I went to a bunch of different job interviews. I had my white shirt and my, you know, my suit and tie, as they say. And I found myself in these interviews having to like pretend to be this person that I wasn't, like thinking of things that I thought that the people that I was interviewing in front of wanted to hear. And finally, I got a call from Community Access. I was intrigued by their harm reduction approach. As a former substance user, I never wanted to work somewhere where I had to force people to like get, you know, urinalysis or tell them that they couldn't use substances. And I was in love with the idea that we could help people use more safely. So when they called me, I was like, you know what, I'm gonna just be myself. I'm over these, you know, phony interviews, and I put on a flowered skirt and a green shirt. And I went in front of this panel and they asked me a bunch of questions and I answered honestly. I talked about like my experiences with, you know, crack cocaine use. And I was amazed that everything that I had stacked up against me, and they were in love with my interview and they called me back right away. And needless to say, I've moved, you know, fluently through the agency. I started out as a service coordinator, and then I was a harm reduction specialist for about 2 years. And now I currently have the role of assistant program director. So, and that was in really a short time. And I think one of the reasons that I'm able to do well in this agency is because of my own lived experience with substance use and homelessness and the HRA and things like that. Because I've been on that side of the table. I've sat in public assistance and had them tell me like, you're not going to get these services. I've been cut off. I've gone through these roles that tenants are currently facing. And because I have this unique understanding, it helps me to be more empathetic and able to like service them better. And I can build like more stronger connections. A lot of times when, you know, people come to me about their substance use, I don't use words like addict or get clean, because they're very derogatory terms, right? Like, who's to say that I'm an addict, like just because I use cocaine? Or who's to say that I'm, you know, oh, you have to get clean. Well, what are you saying? Am I dirty? And these are the things that like I tend to shy away from. And I have this unique understanding where I can say, like, I know what it is to have people say these things to me. Our people have been burnt so long through these systems, HRA and all these, you know, AOTs and ACT teams and you know, even psychiatrists and mental health hospitals, that when they come to us, you know, they're very distrusting. They don't know, you know, what to think about things. And then it's refreshing for them to be able to talk to somebody who can say, yes, I have been there and I've shared these experiences, and through the way that I interact with them, they can tell, oh yeah, she knows what I've been through because, you know, she has this insight. And so I think that's really helped me like progress in the agency and build these unique relationships with a lot of people that I work with. And so, you know, an example of how I do this, well, just like one example in particular, there was a client that I worked with, and when I began in the agency, I started working with him, and then I also transitioned with him as a harm reduction specialist. And when I first met him, he was suicidal. He was on assisted outpatient treatment, or AOT, where he was being forced to take medications. He was being forced to go to see a psychiatrist, a therapist. He had a care coordinator at Blvd Hospital. He was forced into all these things, and he used to come to me. Well, at first he didn't want to sign any papers. He didn't want to be bothered with anybody. But, you know, through my own experiences and talking with him and spending time with him and having conversations, you know, he came to me and he would say, you know, Melissa, I think these medications are killing me, and I want to not take them. But if I don't take them, they're going to hospitalize me. I need help. And so I was able to work with his Department of Mental Health and Hygiene lawyer, and we petitioned the courts, and we were able to successfully get this person off of AOT. And then there was a time when he was like, okay, well, I'm just going to stop point blank, and I'm not going to take these medications anymore. And I had to have conversations with him like, well, hey, you know, it's very dangerous to just stop taking your medications. You have to understand he'd been taking medications via intravenously for about 2 years, every other week. So it's like, for you to just stop taking medications can be very dangerous. And so I had a lot of these conversations with him. And because we had such a strong rapport with each other, he listened to me, and we were able to have a meeting with his psychiatrist, who was not happy, by the way, about me wanting to encourage the tapering of medication. But first we lowered the dosage on his injections, and then we were able to get him on oral medications until finally he was able to stop the medications altogether, and he was very happy. And one of the things that he was like very passionate about was the Jehovah's Witness religion, which, you know, obviously isn't my thing. I didn't know much about it, but he would come down and he would school me. He would, you know, preach like sermons to me, and I would listen. And like, as we built a relationship, I would share with him, you know, certain things that I was going through at the time. I was having issues with my cholesterol, and he was very into like homeopathic remedies. So he would read me articles about, you know, how niacin can lower cholesterol. And he would say, Melissa, you have to eat these things. I can take you to Whole Foods. So it was a very like mutual relationship where, like, as I helped him, he also tried to help me. And there was a time about a year after we had got him off of AOT, he was doing so great off the medication, and our relationship was so strong that he even came to me and he was like, Melissa, I'm struggling a lot with the voices that I'm hearing, and I'm very scared. And I asked him if he wanted to go to the hospital. He was very reluctant, but I explained, you know, like, I can go with you, you know, if we, you know, you don't have to, you know, it's voluntary, because he was so scared that if he went to the emergency room, they were going to put him back on AOT. So we called up his care coordinator. Hey, this is the situation. Will he get back on AOT? They assured him he wouldn't. I told him I had his back. We went to the hospital. He wound up staying for 5 days. They put him back on medication. And he was able to realize that, like, okay, this medication is something that I need for now. And, you know, God rest his soul, he did pass away during the COVID pandemic. But I feel good about what I was able to do with him, because when he did pass away, he passed away the way he wanted to, right? Like, he wasn't on medication. He was free of AOT. And I believe, honestly, that he lived his best life the way that he wanted to up until the day he passed away. And I hope to say that I had like a hand in that. And so that was, you know, one of the greatest experiences for me, as being able to connect and just help somebody that just desperately needed help. And that's one of the reasons why community access is great, because we're not one of those places where we're going to say, like, you have to take your medication. You need to make sure you see your psychiatrist. Like, we don't do that. He asked me to help him get off AOT, and that's what I was there for him to do.
Thank you, Melissa. I'm always anxious about time, so I'm going to step in just for a minute so that we finish our assignment. I wanted to say a few words about community accesses training, because it's not just about hiring the right people like Melissa, it's also about exposing them to the knowledge and skills to work in line with our values. And for that, this includes our core training program developed over the last 20 years that is delivered by peer and non-peer staff to support people in their role as allies. And the series, which we call our core training, which usually happens over about 20 sessions, promotes the sharing of and respect for lived experience, and also provides, among many other things, a critique of many of the pillars of treatment as usual, including the DSM and the damaging intersection of racism, homophobia, misogyny, capitalism, and psychiatry. Melissa was going to talk about this formative training, but I think we don't have time because I'm going to skip to the hopes and dreams for the future, but we'd be happy to share it in the chat, which is an experiential training that helps staff understand the experience of voice hearing. We were asked also to share our hopes and dreams for the future, and I share many of those that were listed by CUCS about how we can help people age in place and what promise occupational therapy might provide or does provide in this context. But my big dream is that rights-based services and supports that put the person in the driver's seat, truly in the center, will be the norm and not the exception. Yesterday, WHO launched a set of tools to promote person-centered and rights-based approaches, and over 6,000 people from across the world were on the virtual launch event. And one of the things that one of the speakers there said that really struck me is we need a system where professionals, and by that I mean anyone in a service delivery role, ask instead of tell. Equally important is that people with lived experience will be greater and greater percentages of the mental health workforce, that our system be free from involuntary treatment so more people can have experiences like those that Melissa described, that we move away from a narrow biomedical approach and have a service system that provides access to a range of holistic non-medical interventions. There is more to support than here is a prescription. And then within the context of supportive housing, we really expand the markers of community integration, that we have more buildings mixing families, that we have economic integration within our system, that we decrease the ratio of people living with mental health concerns in congregate settings so that we can make sure we are not recreating institutions in the community. That's the end.
Thank you so much.
Oh, I'm turning it over to Diane. Sorry.
No, that's okay. Because of time, we are thinking that we would just like to send everyone to our post-forum chat. So we'll be posting a link to a Zoom meeting in the chat. Please join us there. We have a lot of good questions that came through in the chat and in the Q&A that we would love to discuss. So you can come there and pose your question in person or just meet our panelists. Thank you so much, Gabby and Stacy and Cal and Melissa and Diane, of course. And we'll see you all in the Zoom room. Okay. The link is in the chat. See you there.